Good afternoon, everyone, and welcome to this seminar, Managing Diabetes by Gintavenes Health Foundation. You're all welcome, and thank you for joining. Okay, that's fine. So we'll go to our first speaker. Our first speaker today is Patience Chima. She's a registered dietitian and nutritionist, and she's going to be talking about diabetes and diet. So you're welcome, Patience Chima. Over to you. Please unmute yourself. Thank you. There you go.
Okay.
Yeah.
Good afternoon, everyone.
Good afternoon.
You're welcome to Gintavenes Health Foundation Zoom meeting. We'll be talking about diet and diabetes. My name is Chima Patience. I'm a registered dietitian and nutritionist. I'll be taking you through diet and diabetes. Diet, of course, plays an integral role in the management of diabetes. There are about 3 types of treatment in diabetes. You have diet, you have drug, and you have insulin. And in all of this management, diet is very key. So you have diet and the insulin and diet and drug, and then fortunately, some patients can actually be on diet alone. So diabetic patients need to make healthy food choices. They need to understand the food portion sizes, and they need to learn the best times to eat. And learning the best time to eat, understanding their food portion sizes, and making food healthy choices can help them control their weight, achieve good glucose control, and even their blood pressure control. Like I said earlier on, some people may be able to manage their condition for some time without medication. So managing diabetes successfully involves 3 things. It involves food, it involves exercise or activity, we need to plan food intake and drugs to manage blood sugar. There needs to be a balance between the food taken, the insulin had, and the drugs taken to have good glucose control. Now, too much food and then too little insulin can cause a reduction in blood glucose, while too little food and too much drugs can actually cause an increase in the blood sugar. And so it's important that the foods are managed alongside the drugs taken. Before now, people living with diabetes were prescribed a diet low in all types of carbohydrates, rich in proteins and fats. And then the belief that the use of whole grains, legumes, and fruits were discouraged because they had complex sugar and sugar content. And then the belief that they were going to be transformed into glucose during digestion. But now it has changed. Now, dietetic treatment of people living with diabetes is constantly overcoming these old taboos concerning the drawbacks of carbohydrates. And today's dietary recommendation says that diabetic diet needs to be rich in complex carbohydrates, it needs to be rich in fiber, and then it needs to be low in fat, particularly saturated animal fat, and low in simple sugar. And this approach provides better results in controlling blood glucose level, preventing complication, and improving quality of life of the diabetic patients. So what should you eat to manage diabetes, you would ask me? There is no one single diabetic diet. Persons with diabetes have the same nutritional requirements . So persons with diabetes has the same nutrient requirements as any other person of the same size, of the same age, of the same status and activity level. Therefore, there must exist a balance between all the nutrients of food. there is no single one diabetic diet. So persons with diabetes need to take in the same nutrients as those of the same health status and then of the same age. So they need to ensure that their food portions are controlled, not exceeding the total daily allowance per day, while maintaining balance among nutrients, like earlier said. Now, foods from different food groups are needed for energy and nutrients. Your meal plan should contrary to that, you have about 50 to 60% of the total calorie coming from carbohydrates. You have about 20 to 30% of fat coming from fat, and then you have about 15 to 20% coming from protein. So we also need to, now this shows us that we need a balance in all the nutrients. Carbohydrates are absolutely important. Fat is also important. Protein is also important. But what is important is the sources of fat that we're taking in and the sources of carbohydrates. There are a lot of healthy foods that are allowed for diabetic patients. They can have lean meats and they can have a lot of vegetables. We encourage diabetic patients to have a lot of vegetables so that the vegetables can add bulk to their meals, and then the amount of carbohydrates that they are required to take to help them maintain blood glucose is actually adhered to. And some of these vegetables include lettuce, green leafy vegetables, cabbage, broccoli, green peas, green pepper, green beans, cucumber, and all the rest. So we can also do whole grains, can have tea, and all that. So there are some foods that are limited, that are allowed in limited amounts, which include milk, include butter, margarine, oil, porridges, baked beans, fried foods, and diabetic products. You do not just cling to any food that is described as diabetic product and take without control. You need to read labels, you need to know the calories, and then you need to know the quantity you are allowed to take. Now, there are some foods that need to be eliminated or reduced. They include simple sugars, they include refined baked goods, and they also include tea fruits in syrup. So you rather have your fresh fruits that do fruits in syrups. All soft drinks, fizzy drinks, except probably diet drinks, honey, chocolate, alcoholic beverages. Honey, yes, in contention, but honey is a complex carbohydrate and the end product remains sugar. So salts need to be reduced because of blood pressure, and saturated fats, especially from meat. So the question is, when you do reduce the fat from saturated fats, what are the other options you're looking at? You are also looking at we're looking at doing monounsaturated fats. You're looking at doing fats that are not solid at room temperature. You're looking at doing fats that are liquid at room temperature. And another example is omega-3. You have olive oil, you have canola oil, you have sunflower oil. Basically, plants and vegetable oils will do better. But also bear in mind that in as much as it is monounsaturated and it is regarded as good and safe, we also need to know that quantity needs to be moderated, because whatever we do, a calorie of fat remains 9 kilocalories. So we need to ensure that everything we do, the key word for diabetic patients is moderation. Now, there are simple ways that you can actually help yourself to ensure your meals are well taken in. There's the plate method, where you need to share the plate into 4. 1/4 of it will come from your carbohydrates. Another 1/4 will come from your protein, while half of the plate would be from all the your vegetables, and that will add bulk and then reduce the amount of carbohydrates you are having. So, like I've actually said, diabetic diet is, in conclusion, is individualized. It's what works for A might not work for B. So what is absolutely important is what works for you as a person. And that also means that you need to get a personalized meal plan from your dietitian and ensure that the foods you're eating are things that are locally available and affordable and within your reach and will not increase your blood glucose level. So remember, once again, there is no special diabetic diet. a diabetic patient can eat all the food, especially the complex carbohydrates, but in quantified amount and in portions that are in portions that are made for the person based on the calories and the needs for the patient. Thank you very much for listening. Thank you.
Thank you very much, Patience. We have a question for you. Any questions that you may have for the speaker, please could you type them in the chat and then we can put it to the speaker. So someone is asking, please, what does the speaker mean by diabetic product?
Okay, there are products that are labeled diabetic products. You would see them, they're actually written for safe for diabetic, but that doesn't mean that you can take as much as you want. You also need to check the quantity that you require, that you need. You can see there's some jam that's written for diabetic. You see some food items that are actually described for diabetic alone. So what I mean that you can't just take diabetic products as much as you want. They need to be quantified also. In as much as they have been labeled for diabetic, you need to ensure that you quantify it and just do not take it without measure.
Okay. Thank you for that. I hope that answers the question. Somebody's asking, what constitutes lean meat?
What constitutes lean meat is
Yes.
meat without fat. It means that the meat cut does not have fat to it. So you need to shred out all visible fat from the meat. And so if you're going to do your chicken, it has to be skinless chicken with the fat underneath the skin removed. If you're going to do beef, you need to be lean, no visible fat. And then it means that some parts of fat, some parts of meat where you cannot separate the fat and the meat will need to be eliminated, like there's the part of meat that's called torso, cow leg, cow tail. Those areas you can't really separate the fat from the meat. So you need to do lean meat where there are no visible fats at all, and then you can actually have the meat itself, not visible, without visible fats.
Oh, great. Okay. So what's the position of honey? Someone is asking.
Yeah,
More
like I said,
information on the position of honey. Yeah.
Yes, like I said, honey is a complex sugar. Compared to a regular sugar that is a simple sugar that is just absorbed, honey have to go through digestion. So, but at the end of the day, the end product is still glucose. So you need to be taken with caution and not just taken because it's just honey and it's safer. Of course, some will argue that it has some natural properties aside sugar, it's used for wound healing and all that. In as much as it has all the other properties, it doesn't change the fact that it's still sugar. So honey is a complex sugar.
Okay. We have a question for Miriam. As a pregnant woman with diabetes, how do you marry food with quantity since you need to take care of another being within?
Okay, like I said, your food is tailored to you according to the calories you're placed on. So if you're pregnant and you have diabetes, of course, you'll be placed on a calorie. So that calorie will be translated to regular meals for you. And while you're placed on that calorie, it is already taken into consideration the additional calorie required during pregnancy, depending on the trimester you are. For second trimester or third trimester, we're looking at about 300 or 400 kilocalories. That will be added, and then it will be distributed to your meals and in between meals, and then it will be portioned according to that.
All right, great. Okay, thank you for that. I hope that answers your question, Miriam. Next question. Thanks, Chima. You talked about meal times. Please, can you say more about this?
Okay, for people living with diabetes, and then for those that are on insulin, we usually make room for what we call in-between meals, and we ensure that the carbohydrate is actually counted or distributed to meet or to suit the amount of insulin the person is on. So what it means is that if there should be regular time for breakfast, regular time for lunch, regular time for dinner, and the regular times for the in-between meals. So the in-between meals are actually supposed to help you to provide some sugar so that you do not have hypoglycemia. So the calories are distributed into main meals and the in-between meals. So regular timing of meal times. So for breakfast, you're expected to have your breakfast between 7 to 8 a.m. max, and then an in-between meal by 10 or 11, your lunch by 1 to 2 p.m., and an in-between meal like by 4 p.m., and then dinner between 6 to 7 p.m. max. And if you're on insulin, you can do a bedtime snack to avoid nocturnal hypoglycemia, and that could be like by 10 p.m.
Okay, fantastic. We have another question from Fumi. How do you manage the naturally sweet alternatives? Do you treat as sugar like stevia?
Not really. Some of them are sweeteners, and they do not have the same calorie like sugar, and then you can actually use them. Some of them are sugar alcohols, so you can use them.
They can be used. Great, thank you. Any more questions for Patience Chima, please? Okay, we have a question from Nasir. Is there any preferred sweetener that is safe?
I would categorically say you should look out for sweeteners that contain sucralose. I know some people have some aversions about aspartame, though not found in human yet. There are some literature that said can cause cancer in human in animals, but like I said, not been found in humans. So you can do sweeteners that have aspartame, or you can do sweeteners that have sucralose. But if you are not so comfortable with aspartame, you can do sweeteners that contain sucralose, because the body does not digest it. So you can do some examples are the stevia, the splendor, the tropical slim, and all that sweeteners.
All right, okay. So sucralose is the one to look out for, yes? Products containing sucralose, is that right, Patience?
Yes.
Okay, great, okay. Donald is asking, what is the place of crackers as a snack? There's a particular brand he's named, but I'm just going to say crackers in general. You know the one I'm talking about, yeah.
I know okay, it can actually be taken as in between meal, but if you're going to do your cracker biscuit, you have to choose between the cracker biscuit and the fruit. So if you want to do cracker biscuit as an in between meal, fine. You can do Jacob's cracker biscuit, like he has stated. It's quite bland and does not have much sugar. So you can actually do it. It's plain, basically. Let me use the word plain. So you can actually do that as an in-between meal, but you have to choose between that and a portion of fruit as an in-between meal. So if you're going to do cracker biscuits, you will not do a sweet fruit with it, but then you can do the cracker biscuits and tea as an in-between meal.
Fabulous, thank you very much. Okay, let's see if there's any more questions for you. I can't see any more. So thank you very much, Patience. Yes, thank you. So we'll now go on to our second speaker. And I'll just introduce our second speaker. Our second speaker today is Dr. Carol Gale. She's a consultant diabetologist, trained in medicine at University College Hospital, University of London. She also has an intercalated degree in a BSc in nutrition, also from King's College London. She's had specialist training at King's College Hospital, and her areas of interest are diabetes in pregnancy, diabetes and psychological health, system change and development of community diabetes. She will be speaking on lifestyle and the change needed for diabetes. Over to you, Dr. Gale.
Hello, can everyone hear me?
Yes.
Okay, thank you. If it gets difficult, I will turn my video off as well. So firstly, as I've been introduced, my name's Carol Gale. I'm a consultant diabetologist since 2004 at King's College Hospital. So thank you very much for inviting me to speak to you all. I'm going to speak about diabetes lifestyle, but focus on activity and try to help people to understand what we mean by the term pre-diabetes, which has sort of become introduced into people with diabetes and language. Hang on. Ooh. Hang on, my slides doesn't want to go forward and I'm not sure why. Here we are, that's it. Okay, so my apologies about that. So for this slide, I really want you to focus along the top part. I call this the spectrum of diabetes. Before pre-diabetes, you can be considered normal in terms of your blood glucose handling. But we all have risk factors that can change our risk of developing pre-diabetes and then progress into type 2 diabetes. though there's increasing evidence for the remission of type 2 diabetes. For every one person that has known to have type 2 diabetes, there are approximately 5 who actually have pre-diabetes. And this has important implications. So what I'm going to really focus on is this part here, which is to explain pre-diabetes, explain what it is, what are the implications of having pre-diabetes, and what you can do to reverse it, to protect yourself from developing or delay the development of type 2 diabetes. So pre-diabetes is essentially the stage where you're increased risk of developing type 2 diabetes, and it's reflected in documented changes in your blood glucose values. These changes means that your blood glucose values are above normal, but not yet high enough to meet the values we use to diagnose type 2 diabetes. Pre-diabetes isn't actually an officially recognized term under the WHO. However, it has entered into common language, but there are alternative names that you may have come across, such as borderline diabetes, which healthcare professionals may often talk about if you've had a check, impaired fasting glucose, impaired glucose tolerance, impaired glucose regulation, and occasionally some people who've developed high blood glucose, but not related to diabetic reasons. In terms of language now, it is commonly used. I've listed underneath here some useful web links that provide it's free, accurate diabetes information, both the Diabetes UK website and the American Diabetes Association. And I found that they both had excellent information around preventing type 2 diabetes, and also both have risk calculation scores. What I would say is now, if I can get my cursor here, over here, in terms of pre-diabetes, they do have defined diagnostic criteria attached to them. Though interesting enough, it does vary. So the most common measurement used now is a term used, glycated hemoglobin. Those of you who have diabetes will know that's the test that's used to measure your control and reflects your blood sugar control over the previous 3 months. In the United Kingdom, the diagnostic range is 42 to 47 millimoles per mole, or 6 to 6.4% for pre-diabetes. And in the USA, it's 39 to 47 millimoles, 5.7 to 6.4 millimoles. If you've had what's called an oral glucose tolerance test, it would reflect if you had a fasting glucose between 6.1 and 6.9 with a normal 2-hour value, or the 2-hour value more than 7.8 but less than 11. So they imply that there's some mishandling of your blood sugar regulation, but it's not sufficient to meet the diagnosis of type 2 diabetes. So what is the practical implications of having been told that you've got a diagnosis of pre-diabetes? So this slide really reflects, and I'm going to show you an example of these risk calculators, the clinical application of that. So this is on the Diabetes UK website. Once you've gone through the risk calculator, which is very quick to do, takes less than a minute, it can gives you a score that can be ranked from low to high here. And what the implications of the score is, it can give you an understanding of what your 10-year risk of developing type 2 diabetes is in the future. So if you're low risk, it's 1 in 100. So you could recognize that this is the background rate for the population, it's about 1%. If you have a slightly increased risk, it's 1 in 35. Moderate risk is 1 in 10, and high is 1 in 4. So these two lower categories have significant risk attached to them. And it's recommended, certainly on the Diabetes UK website, that you should visit your healthcare provider. If you were in the United Kingdom, that would mean that you would, I know we live in a world of COVID and lots of healthcare is different, but in the great scheme of things, that when life is calmer, you should try to have a free health check, including a simple blood test to look for evidence of pre-diabetes. And I've given you the link, so if you wanted to go and do this, and interesting enough, there's already 2 million people that have done it. The American ADA also has a risk tool. It does include slightly more risk factors because it does talk about gestational diabetes or polycystic ovaries for women. Hang on, sorry, clicking on the wrong bit. So this is an example of the Diabetes UK risk calculator. So I put myself in, and then it expresses the risk factors, which I will go through, and it divides them up into two. So the first group are risk factors that you can't change, which includes your age, your gender, your ethnic background, and if you have any first-degree relatives with diabetes. So that means your parents, brothers and sisters, or your children. And then the second half of it focuses on areas where you can make changes that can make a significant difference to your risk. Here. And where lifestyle interventions are important. So one of the only tip I would say when you go into this is that you should have measured your waist before, your waist measurement before you do the calculator, because that's the only thing that you may not know. And why have they used these particular measurements? So waist measurement is important as it reflects where you're more likely to put on your weight, because it has different health implications. So if you put weight on around your middle compared to putting it on around your bottom and your thighs, that means you are at increased risk of conditions such as pre-diabetes, diabetes and high blood pressure and cardiovascular disease. Sometimes that's been described as apples and pears in terms of your shape, and that is something that is genetic, and obviously you can't change that, but it can be adjusted or reflected in weight loss. Your BMI is a way of expressing your weight in relationship to your height, and the simple question around if you've had high blood pressure, yes or no. So the next question is it important? Sorry, because I can't see the slide. So the answer is yes, it really is very important. This slide reflects one of three major lifestyle interventions studies that were done in the late 1990s. So this is information that we've been aware of for a very long time. The first was done in China, then in Finland, and then this one's from the Diabetes Prevention Study Group in the USA, which also had an arm where they gave metformin. The study took individuals who were known to be at high risk of developing type 2 diabetes and looked to see if they could delay progression. There were just over 3,000 people in the study, and they were divided into three groups, and they were followed on average for 3 years. So the first group was placebo, which essentially meant that they had no intervention and they just carried on with their usual lifestyle. There was a second group where, again, they were given no advice about lifestyle changes, but they had metformin. And then the third group had lifestyle interventions, which included dietary changes with a view to aiming to lose 7% weight loss, and 50% of the participants achieved this at 24 weeks, and activity aiming for 150 minutes, which if you break that down to about 25 minutes a day, which feels more doable, and 74% of them achieved this at 24 weeks. Now and this to me is the most important table graph in the paper, because what it essentially showed was several things. So firstly, it showed in those where you did nothing and you just left them to their usual behavior, they had a significant progression to type 2 diabetes, which was about 35%, which is very high. It showed that metformin did make a difference and decreased that by about 30% overall, but it showed very, very clearly, this is this green line here, that lifestyle was the most powerful intervention and actually decreased your risk of progressing to type 2 diabetes by about 60%. And most people don't like the idea of taking medications. And I think that's incredibly powerful that you know you can do things by doing things a little bit differently in terms of what you eat and what you do. One of the things that I haven't got in here, but I think is really helpful, that most of the individuals who entered these studies, so these three studies cover lots of different populations, so that's really helpful. And most of the people that went into the study were overweight. The weight loss gain targets were modest. So 7% for many people, that might have been about half a stone or 3 kilos or 7 pounds, depending on which units you use. And it was combined with increased activity. So I call it becoming a slightly healthier version of yourself. We're not talking about extreme weight loss here, which I think most people probably would feel was doable. So I'm not going to talk about diet. We have had a good talk from Chima, Miss Chima, my apologies. And essentially, I'm going to talk through this infographics. These and other studies have led to recommendations of physical activity for adults. This one's from the UK, the government UK website. I simply put in a search, which was UK physical activity guidelines. And it led me to a series of pages, and they've got a series of infographics that are easy to download. I've used the one here, which is physical activity for adults and older adults, because it's the group that I'm hopefully speaking to, but they also have them for children. And I think these are very free, good resources that, you know, depending on what you do, but if you're a healthcare professional, it's very easy for people to understand and get a feel of. And, you know, because sometimes it can be, you know, when you're sort of trying to translate medical terminology into everyday language, you want to make it easy. So firstly, and this is very much a summary, physical activity, irrespective of whether you have pre-diabetes, diabetes, or any other health issues, is incredibly beneficial. It's beneficial to your health. It improves things like sleep. It helps you to maintain a healthy weight, manage stress. And we've all lived in an increasingly stressful world in the last year with COVID, and improves your quality of life. What does that translate into from a healthcare professional's point of view? Well, it can decrease your risk of progressing to developing type 2 diabetes by 40%, decrease your risk of cardiovascular disease such as stroke, heart attacks. It helps your mental well-being. You're much less likely to get issues in terms of mental health, such as depression. It helps your joints, joint and back pains, and often, which is not talked about, it can significantly decrease your risk of cancers, including colon and breast, and then there are others as well. Many people feel physically daunted by the idea of physical activity, but you all have to start from somewhere, and we all have to, and starting small and building up is the best way to go. Try not to remember how fit and healthy you were when you were 20 or 30, because you're not going to be able to do that. You will end up in a chair or in a bed groaning with pain for several days. It's better to start with 5 minutes and then think I'll add 1 or 2 minutes each 3 or 4 days. And then after 4 weeks, you'll suddenly think, oh, I can do this. So some is good, more is better. Make a start. It's never too late. You have to make that decision about which is going to be day one. When are you going to do it? What are you going to do differently? And really think about it. Make a commitment to yourself. And they do talk about how many minutes that you could try to achieve, and that every minute counts. So the interesting thing about physical activity, it has 3 components. It's physical activity that gets your heart rate up, it's strength training, and it's balance. And the strength training and balance is particularly important once you're over 50. So the activity is 150 minutes a week, which is moderate. In practice, that means you're breathing. It's what I call, if you're a bit late for an appointment, you've got to walk a bit faster. So you know that you're feeling a little bit breathless, but you can still talk, or you can trade it for some more vigorous intensity where it's only there for half the time you need to achieve it, but that's where you are breathing fast and you would have a bit of difficulty talking. I think, and I'm going to emphasize this on there, they do talk about sports, swimming, cycling. I would start with brisk walking, and how can you integrate that into your day to feel that it's realistic? Things like taking maybe 1 flight of stairs rather than just getting into the lift, more active exercise like running and sport. But it doesn't need to be just about sport. It can be about the everyday. Strength training is particularly important when you're over 50 for helping to maintain your muscles, bones and joints. Again, they've got here, they're showing you somebody going to the gym lifting weights. Well, actually, you can do that in your living room with, I would say, 2 cans of beans, forgive me, the dietitian, 1 in each hand. And you can find good programs on YouTube that are free to follow. Carrying heavy bags if you carry your shopping, things like yoga or Pilates, and balance. It's got bowls, Tai Chi, dancing. You want to keep it really simple, stand on one leg and then stand on the other. And I am being serious because our balance does deteriorate as we get older. And then in our days, many people now have less physically active jobs sitting at desks. It's good to get up every couple of hours, and walk around for 5 or 10 minutes. And actually it makes a significant difference to your health risks as well. So some of the things which I haven't talked about is that to be able to be active, and I talk about activity rather than exercise, that's great if you do go to the gym or you run, is that you need to have a safe environment. You have to take into account, you know, different climates. If it's really, really hot, you're not going to be able to walk with the same kind of intensity, and you may have to choose to walk at different times of the day. Your job may be active, so you may get all this. You need to aim to integrate it into your everyday, i.e., you know, walking to work. Do you get off the bus stop or the tube one stop earlier? Maybe on your way home to walk a little bit more. You can get your activity without having to do exercise. So things like gardening, dancing, you know, you may have quite, you know, do a physically active hobby, and you'll get it that way. I've put here chasing children, tracing your grandchildren. And it needs to be something that you're going to enjoy, because that increases what we call adherence, and that you're more likely to then continue to do it for the future. Modest changes make significant health benefits, as I've said, including prevention of many quite serious medical conditions. It's never too late to change. Remember strength and balance once you're over 50. And depending on which country you're in, because I was told it was an international audience, there are many lifestyle prevention programs, particularly if you do have pre-diabetes. And for example, in the UK, your GP will have an awareness if there's some local programs in your area. Like in my area, we have something that's called Walking Away from Diabetes that can help people to understand what they can do to help themselves. So in summary, lifestyle is fundamental key to pre-diabetes, people with type 2 diabetes or diabetes remission. Modest changes gives you significant health benefits. It's never too late to change. Get checked and ask about prevention programs. Thank you. And if there's any questions.
Thank you very much, Dr. Gale. Do we have any questions for Dr. Gale? Okay, so Emmanuel is asking, great in measuring waist size. What do you mean by apple and pears?
Okay, so sometimes it's an easy way to visualize what your body shape is. So people who tend to put weight around their middle, I would usually say they have great legs, all right? And they're more an apple shape. So you're more rounded, and you don't tend to put on much weight on your legs, and they're slim and muscular, and similarly, maybe your upper body. So the weight is around your middle. There are other individuals who we talk about pears, because you will tend to have more weight around your bottom and your hips and a slimmer waist. So that's what we mean by apple and pears. Now, if you're an apple shape, unfortunately, putting that weight on around your middle increases your risk of many of the conditions I've been talking about today. That is genetically programmed. And obviously, you can't change that, but you can change your weight. And interestingly enough, people with apples, when they lose weight, they lose more weight from their middle, which gives them more protection against these health conditions than people who are pear-shaped.
Great, thank you. Emmanuel, I hope that's answered your question. The next question we have is, would you advise intermittent fasting for pre-diabetics?
I think
pre-diabetes.
There is, it's evolving. I have to a series of talks at the recent ESD this year in September online. I think there are lots of factors to take into account. For some people, it works really well. I think it depends on your style and how long you fast for and how long you can maintain it. But for some people who feel that they have real issues with their appetite, and the only way they can regulate their food intake is to intermittently fast, which may be 12 hours or 16 hours, 18 hours, I think is quite difficult. It can work very well for them, but you have to think, is that something that I can do for the short term and long term? But for some people, it can work well. For other people, it's not their styles. And I think with pre-diabetes, where you're not on any medication, that may be quite a successful strategy for some.
Okay, great. Miriam is asking, when you live in a 3-story building, can you classify walking up and down the stairs as a good exercise every day?
Absolutely. And that's what I mean about doing things differently. The temptation often is if there is a lift in the building, to get the lift. And it's about saying, okay, it's a safe environment. I can go up and down the stairs. And particularly if you're carrying your work bag or shopping, then you really are adding to that exercise and that activity. And it's often that sort of everyday activity that people don't think about.
Right, okay, so it's incorporating it into your daily routine, really.
Yes.
Yeah, okay. So we have Finri asking, in cases where the pre-diabetic patient gets hypoglycemia from all the exercise, how can it be managed?
So I think as an area, I would say pre-diabetes and low blood sugars is not a well-researched area. I think some people, anything is possible, and some people are more sensitive to changes in their blood sugars. So they may be aware of when their sugars are moving from being, if you like, in a higher range and then it's coming down, but they may not necessarily get hypo. I think if you, I'm not quite sure, in case we're, right, I think you have to also think about exercise and hypoglycemia. So for example, if you don't have diabetes, but you drink a lot of alcohol, you can get a low blood sugar because you've depleted your liver stores. So there are situations where that can happen. So my advice, if you were an individual where you felt your sugars were dropping significantly after a lot of exercise, is it's part of exercise advice, is that if you're doing prolonged vigorous exercise for more than 45 minutes, you do actually need to take some carbohydrates during your exercise in the region of 10 to 20 grams, maybe every 2 hours. We are talking, after the first hour, certainly. But then you're talking about real extremes of exercise, vigorous exercise that's going on for more than 45 minutes. Or you could make sure that you have a 10-20 gram snack before you start exercising, rather than running on an empty stomach. And those strategies then will give you a bit of carbohydrate reserve before you start.
All right. I mean, if someone who is pre-diabetic, can they be hypoglycemic?
Anyone could, in theory, get a low blood sugar in the right or wrong circumstances, like if you've drunk loads of alcohol, because it depletes all your liver stores. And extreme exercise, it is actually part of the routine recommendations that you do need to have some carbohydrates during the training. So the answer is anybody could, but you have to take yourself to extremes to do it. There are a very, very small group of people who get something called reactive hypoglycemia, where their sugars do drop after 3 to 4 hours after eating. And for them, it's about having regular complex carbohydrates that patients was talking about, and avoiding the simple sugary carbs, because that really causes their imbalance.
Okay, right. There's another question about pre-diabetes. Would you prescribe a combination of metformin and physical activity in the long-term pre-diabetic?
I think this is an area of growing change, because it's for debate, and I'm going to apologize because I do know that there's been an update about it. Many people felt, I suppose one of the things I feel quite strongly about is that lifestyle underpins anything that you do in terms of diabetes or living with type 2 diabetes. And for some people, it can help, because it does, metformin acts as what we call an insulin sensitizer, so your body responds better to the insulin you make. But you've got to make sure that psychologically someone's not taking the metformin and therefore thinking they don't need to do anything lifestyle. It's got to be in combination, because you saw from that slide that it's not as good as lifestyle, but it may be better when you combine the two. Nobody's done that study.
All right, we have a question from, their name is not on the screen. It says Nokia C1. They've raised their hand. I'm just going to allow them to ask their question. Go ahead, Nokia C1. Were you raising your hand to ask a question, or was that a mistake? All right, okay. Let's move on. Next question. If you have a tummy that is 46 inches, a male, is that a significant risk?
So the answer is yes. And I apologize, because I should have said, in the risk calculator, you will get a different waist measurement for where the risk is if you're male, but it's slightly higher cutoffs. But 46 would put you in the risk range. And even if you didn't have diabetes, it puts you in a higher risk range for developing type 2 diabetes, developing high blood pressure, cardiovascular disease, stroke, heart attack. And that's why modest weight change is important, because reducing your waist size makes a difference as well.
Okay.
But if you've got access in it, do go to the website. I think they're going to be uploading the talks onto subsequently YouTube. So that's why I put the web links in there so you can find them easily. You don't even have to, you can get them to email you the results of your risk calculator, or you can just look at it online if you don't want to keep it as a record to give you that information.
All right. Okay. Again, another question about pre-diabetes. Is metformin the medication you just get off pre-diabetes, in which case you stop once you're off pre-diabetes? Does that make sense? If someone is pre-diabetic, from what I understand, do they put your metformin and then once you're not pre-diabetic, then you come off? Is that, I think,
right? So
not
yes.
sure.
So traditionally within the United Kingdom, they have not used metformin to treat pre-diabetes, or it's only been done after a discussion with your GP, weighing up the pros and cons. The intervention programs that are pretty much national now really focus on lifestyle interventions to try to get you to reverse yourself back into the normal range. There has been a recent update, and I apologize because I actually haven't had a look at it, and it may well be that in future there will be a drive to using metformin. The issue then is if you go into the normal range and you stop the metformin, we don't know if that will then take you back to the pre-read range, and you would need to have that monitored with your GP. And that's why I say the underlying benefits of the lifestyle is what's so important as well. Okay,
I mean, in terms of lifestyle, what is the effect of smoking on diabetes?
Ooh, sorry, does that make to answer the question? Smoking is, there's no way around me trying to be nice about this. It's terrible if you have diabetes. So if you look at your risk of things like cardiovascular disease and smoking, if you say your risk is, and I don't know the full risk, but if you said it was 2 times for somebody who smoked and had heart disease, if you have diabetes and heart disease and you smoke, the risk is not 2 times 2, it's more like 6 to 8 times. It's why smoking prevention is one of the questions we're meant to ask everybody with diabetes when we see them, to try, if they can't stop, to at least reduce, because it makes such a huge difference to your long-term health.
Yes. Okay. So stopping smoking is a good idea.
Yes.
Basically.
Yeah.
All right. So someone's asking, is diabetes a factor in developing erectile dysfunction?
Yes, it can be. If you have any form of diabetes, in the long term, it can affect the nerve endings in all organs of the body. We tend to talk about the heart, things like heart attacks and stroke, and circulation in the feet. But again, if it affects the circulation or the nerve endings, that can contribute to erectile dysfunction.
Okay. I have Anthony asking and commenting, Dr. Gale, many thanks for this comprehensive presentation. Is there an increased risk of COVID-19 in someone with diabetes?
Yes. That's the simple answer. The factors that increase it and make it higher if you have diabetes is, in theory, the rates are higher if you have type 1, but by far and away, the largest number of people, certainly with the diabetes population that have had it in the UK, have been type 2 diabetes by a significant amount. The factors are, if your diabetes isn't well controlled, so if that long-term value is above 86 millimoles per mole, that not only increases your risk of getting COVID, it increases your risk of having a more severe case, and it increases your risk of dying. If you have significant diabetes complications, I'm afraid that is also true. So I know people don't like taking their medications, but this is a time that if you're not keen on them and you don't normally take them, you should, because just lowering your blood sugars will offer you significant additional protection from COVID-19, in addition to all the social distancing factors.
Great, thank you. I think those are all the questions for now. Oh, okay, there are more coming in as soon as I said that. Question from Nottingham: how often should I be seeing my doctor to optimize my diabetes management?
I would say that ideally at least twice a year. I think that for all of us, we tend to pay a bit more attention the more that we're engaging or discussing our health issues with somebody. I completely recognize that during COVID that's just been really, really difficult, and it's often even difficult pre-COVID. And particularly because in your early stages, you may not be on medication where you're encouraged to monitor. So then the only way you'll know if you're staying on track is to have the blood test, and that has to be requested through your healthcare provider.
Okay. Miriam is asking, what is the adverse effect of uncontrolled diabetes in first trimester pregnancy? Could it lead to a miscarriage?
So the answer is if your diabetes is poorly controlled in the first trimester, it is associated with a higher rate of miscarriage compared to somebody whose diabetes is well controlled or somebody who doesn't have diabetes. It's also associated with an increased risk of abnormalities because that's when the baby's developing its organs. So again, in an ideal world, we ask people to plan pregnancy, to use contraception, and make sure that their diabetes is well controlled, and then stop their contraception to get pregnant. We also, just as information, you need to be on a much higher dose of folic acid than that's recommended. So the over-the-counter dose is not anywhere strong enough, and it usually needs to be prescribed the high dose of folic acid. So yes, again, focus on your, and also particularly type 2 diabetes, some of your medications may need to be changed for pregnancy because they're not suitable for the fetus development.
Great, thank you very much, Dr. Gail. We'll give you a rest now. Any more questions, we'll take them at the end. So we'll move on to the next speaker. Thank you very much. Okay, so our next speaker, I'll just, Dr. Gail, have you stopped sharing, Dr. Gail?
Sorry, apologies, I'll do that now.
I think you had, let me just see. Yeah, you have stopped, that's fine. That's great. Okay, so our next speaker is Professor Olufemi Fasah. He was appointed consultant endocrinologist in 1997 by the General Hospital in Lagos Island, where he was from 1997 until 2002. He is the head of the unit at he's unit head of endocrinology, diabetes and metabolism at Lagos University Teaching Hospital, also known as LUTH. He is an accomplished author and speaker and trainer, and is well known in Nigeria and now globally. Over to you, Professor.
Thank you. So thank you very much, Gintavenes, for having me on this program. And thank you to all the audience and all the technical crew. Today, I'll be taking the presentation from where Carol Gale stopped, and I'll be honing down on the drug treatment of diabetes mellitus. As they have introduced me, my name is Olufemi Fasah. I work at the Lagos University Teaching Hospital. And this will be my outline. I'll talk generally about diabetes management, a lot of which Carol has helped me to cover. And then I'll then go down into more details on the different drugs.
Professor, share your screen, please.
Okay, am I? Oh,
yeah, we can't see your slides yet.
Oh, I thought I was. Sorry, let me go back there. Forgive me. So share screen. 1 second. Okay, sorry. I thought I was sharing the screen. Okay, good. Share. Okay, slideshow. Sorry for that lapse. Yes, so this is where I was. I said that we'll be talking about the management of diabetes, which covers both the injectables and the oral medications. And we'll start with the injections. A person with type 1 diabetes always has to be on injectables, and usually that is insulin or insulin analogs. There are many brands of insulin in the market. Some of them are short-acting, some of them are long-acting. Some of the names they bear are names like Actrapid, Novolin, Humulin, Mixtard. All these are different types of insulins. And usually your doctor will tell you the one that best suits you. Also, your lifestyle will also determine which one you are placed on. There are other drugs that look like insulin, they behave like insulin, but they are not exactly insulin. We call them insulin analogs. And most of them, when you look at their names, especially the trade names, you will see a log at the end. For instance, it will be bearing Humalog, Novolog, and so on. These are insulin analogs. There are other medications that are also injected in a person with diabetes, but they are not insulins and they are not insulin analogs. These include medications such as liraglutide, which is marketed as Victoza, or exenatide marketed as Byetta. There are a long list of names of other drugs in this group, but usually type 1 diabetes patients are almost always on insulin and insulin alone, while the type 2 diabetes person is either on insulin or tablets or a combination of both of them. When we're talking about oral glucose lowering drugs, there are a long list of them, and the physicians and scientists will put them in different categories. The first group of drugs that was made for taking care of diabetes was the group called the Biguanides. Currently, there is only one drug in that group, and that is Metformin, which is most popularly sold as Glucophage. And this is the most popular and one of the safest medications that has been in use for diabetes. So you find out that between 50 to 80% of people who are on tablets for diabetes are on Metformin, alone or in addition to other drugs. The second group of medications that was formulated for treating diabetes is the sulfonylurea group, and that contains medications such as glibenclamide, glimepiride, and gliclazide, all of them being sold as Downhill, Amaryl, and Diamicron. There is another group of drugs called the DPP-4 inhibitors. This is relatively newer than the other two, maybe it's just about 2 decades old, and these include drugs as listed on the screen. A fourth group of drugs is thiazolidinediones. This drug group has been in market for about 3 to 4 decades also, and it includes pioglitazone and rosiglitazone. Currently, mainly pioglitazone is the surviving medication in this group of drugs because rosiglitazone was found to be relatively unsafe on the cardiovascular system. So you find only pioglitazone. There is another group of drugs called the alpha glucosidase inhibitors. It's quite a mouthful, and it contains drugs such as acarbose and voglibose. This drug causes quite a lot of flatulence, so it's not so popular, marketed as Glucobay or Voglinum or voglibose. Then the last group of oral medications is the sodium glucose transporter 2 inhibitors, also called SGLT2 inhibitors. And this contains drugs such as dapagliflozin, empagliflozin, canagliflozin. All of them in this group, you find their names ending with something zin, 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 zin. And the drugs there are Forxiga, Invokana, and Jardiance. So these are some of the medications that are available for patients to treat their diabetes. I have deliberately not put in the doses there because you can't know the medication or the dose to take without going to see your doctor. This presentation does not serve as a shortcut. To combine treatment for patients who one group of drugs is not sufficient to control the blood sugar, what we do is we combine one drug from each of the groups. And then sometimes you can combine 2 different types of insulins also. Why do we want to put a person on medication? Well, you do so because you want to alleviate the symptoms of diabetes, or you want to normalize the blood sugars, or you want to prevent complications. And quite a number of the medications help patients to achieve their normal weight for their height. Also, you want to improve the quality of life and also to increase lifespan. So this is the aim of using the various medications. Don't wait for your medications to finish before you restock. Don't use drugs that were not prescribed from you. I notice sometimes my patients in the waiting room, each of them compares notes and someone advises the other to try his own medications. Every patient should watch out for side effects or adverse reactions and report to the nearest doctor, family doctor, or the community pharmacist. Many of our patients have quite a number of medications. They have antihypertensives, they have anti-diabetic medications, and so many others. So you must label them well. And sometimes when the doctor does dispense them inside envelopes or inside containers, make sure you don't throw away the packs so that you have an idea of what you are taking. If it's necessary, meaning maybe if you are getting old and you have so many medications, have someone arrange your tablets in a pill box. And if you're forgetful, don't be ashamed to call your wife or your daughter or son to help you with the medications, because taking the wrong dosage or the wrong medications can lead to emergencies. Safety precautions. Every person with diabetes should not skip his meals. If you have to embark on the Lent or Ramadan, make sure you have consulted your doctor before doing that. Don't skip your medications either. For you to stop medications, try and get professional advice. Please don't use native concoctions or herbs along with your drugs, and make sure your blood pressure and blood sugars are monitored regularly as you are taking your medicines. Make sure your drugs are from a reliable source. Don't buy drugs from the open market or from hawkers. Always remember to keep fit, exercise regularly, just as the previous speaker mentioned, and that way you remain healthy. Always budget for your drugs. People budget for their rent, they budget for school. Make sure you have a budget for your medications. So in summary, there are several drugs for treating people that have diabetes. Diet and exercise are very, very important parts of the treatment, which you can't ignore. Make sure you use the medications as they are described, except when your doctor advises on modifications if things are changing fast, and don't combine native or herbal medications with the ones that are given to you by your doctor. Thank you very much. I'll be willing to take your questions shortly.
Thank you very much, Prof. Please stop sharing the slides, and then so that everyone can see you.
Stop share. Okay, thank you.
All right, great. Okay, so we have a few questions for you. First one is, what are the dangers of taking steroids in a patient who's diabetic?
Yes, for people who have diabetes, steroids such as prednisolone, which are one of the commonest steroids prescribed, usually will cause a rise in the blood sugar. So prednisolone, dexamethasone, even oral contraceptive medications, which also are steroids, might all cause the blood sugars to go up. So if a doctor does prescribe steroids for you, monitor your blood sugar more closely, and then advise your carer if the sugars starts going up.
Okay, thank you. What is the best drug to add to metformin for good control?
Well, most of the guidelines will tell you that after metformin, you can add almost any other medication. But the older guidelines will tell you that after metformin, you move to the sulfonylureas, and then from there you move to the TZDs, or you move to the DPP-4s. So it depends on what your doctor prescribes, and he will prescribe based on how high your blood sugar is, what your BMI is, and what other comorbidities you do have.
So essentially the treatment is tailored to the patient,
yes,
each individual, yes. Okay. What is the recommended temperature to keep your insulin at, especially for a frequent traveler in temperate regions?
Usually what we do advise persons with diabetes to do is to keep their insulin in the fridge. If in your regular refrigerator, water gets frozen, then you can't put insulin there, or you reduce the temperature in such a way that you don't have frozen things inside, because once you freeze insulin, you've more or less destroyed it. So just put it in the vegetable compartment or the lower part of your fridge, or turn your fridge to almost the lowest. If you don't have a refrigerator in hot places in Nigeria, we advise people to put the insulin in a bowl of water and place on the floor, or put behind a water pot, which these are the coolest areas in the room. For those who live in cooler climes, in Europe, especially at this time, even putting your insulin on the table won't be harmful, especially if you're not using much heating. So insulin is best stored at temperatures of 2 to 8 degrees Celsius.
So is that different to when it's open and when it's not opened?
Once insulin has been opened or used, it has some stability of 3 to 4 weeks. So even if you don't have a refrigerator, you can keep insulin for about 3 to 4 weeks at room temperature. But the longer you keep it, the less potent it becomes.
Okay. There's a follow-on question from Miriam. How do you ascertain that the insulin used is no longer good or has gone bad, such as to know when you need a replacement?
Okay, if you've kept insulin open for more than a month, then you should replace, whether it's in the fridge or not. But if you have like a pack, maybe you bought a pack containing 5 pen fills, you could keep them in your refrigerator for as long as possible. Once they are not in use, just make sure you watch the expiry date. They can stay for a long time in your refrigerator. The other way to know insulin is bad is if the expiry date has been exceeded, then you shouldn't use such an insulin anymore. Or if you find one day that the insulin is frozen, then you shouldn't use it, even if you just opened it yesterday. That insulin is no longer useful. If you forget your insulin in the dashboard or on the dashboard of your car and you're in a tropical country, maybe you go shopping and you left it there, by the time you come back, that insulin is useless because most likely it has heated up beyond 30 degrees. You've cooked the insulin. All those insulins are no longer good. If an insulin was supposed to be clear like water and now is looking cloudy, then it's no longer good. Or if the rubber cover has started to dissolve in the insulin and you see particles, such an insulin is no longer good.
Okay, thank you, Professor. There's a question about weight loss with metformin. I'll let you answer it. My patient is on a full dose of metformin and has been complaining of weight loss. Is there a link? Yeah.
Yes, metformin in high doses does cause weight loss in a number of patients. Normally it's weight neutral, but patients who are on like 2 grams a day, many of them will experience some degree of weight loss. So it's not unusual, which is why I said in one of the slides that some of the medication will also be prescribed based on things like your BMI, your age, and so on. So if I see an obese patient, I'll make sure that metformin is one of the medications I put such a patient on, and most likely the maximum dosage.
Yes, thank you. Patrick is asking about food and drug interactions with diabetic medication. How do we handle food-drug interactions?
Yeah, that is why if you have diabetes, make sure that you get your prescription filled and you take it to a pharmacist. A pharmacist is likely to tell you how to take the medications and warn you about drug-drug interactions. One of the drug-drug interactions that we worry about is when you're using a sulfonylurea and then things like anticoagulants or NSAIDs like diclofenac and others. Usually they potentiate each other because they displace each other from protein binding sites. But there are so many other drug-drug interactions. So when you have a long list of drugs, you get to the pharmacist, ask him or her, please, can you advise me, is there any interaction I should expect? And if you notice anything that is unusual, please report to the doctors because there are pharmacovigilance lines that we use to advise, that we send our reports to, and then use that to generate advice for patients and for the carers.
Great, thank you. Insulin pumps, are they used in Nigeria? And someone is asking, what are your thoughts on the use of insulin pumps?
Insulin pumps are a very, very important tool in treating people with diabetes, especially those with type 1 diabetes or long-standing type 2 diabetes. that can't usually be controlled with oral medication. We do not have any company in Nigeria that sells insulin pumps, and I'm not too sure we have any insulin pump that has been licensed by NAFDAC. So that is a major minus for us in this country and many parts of Africa. But where it is available, you need to ask your doctor. But usually what we do, or those who use insulin pumps, are usually patients who have type 1 diabetes or type 2 diabetes, patients who are very, very motivated and are ready to check their blood sugars regularly. Those are the type of people who will benefit from using an insulin pump.
Okay, thank you. Someone missed what you said about insulin in temperate situations like in your car. I think you said that if it's left on the dashboard and you go shopping and come back, especially in a hotter climate, you would have cooked the insulin, so that insulin would be useless. But you want to just repeat what you said?
Yes, I just said, you've already mentioned it. Any insulin that you leave and becomes warm or hot is useless, even if the heat was just for 5 to 10 minutes. So don't keep your insulin on top of your car or on top of your dashboard. Instead, you could put it in an ice pack or a carrying container that has an ice pack.
I hope that you got that. Exchange media, I don't have your name, so Prof has just repeated what he said. Is Daonil still routinely used for type 2 diabetes?
Yes, glibenclamide is the active ingredient inside Daonil, and people still use it. It's just that usually when you are seeing a new patient with diabetes, Daonil or glibenclamide is not one of the first drugs you want to put patients on. It's no longer as popular as it was before.
And why is that? Just for the benefit of those that don't know.
Now people go for safer sulfonylureas, the second generations, such as glycoside, glimepiride, because when you use Daonil, it has a very long half-life. And that means if you have hypoglycemia while you're on a drug like Daonil, you may be in coma for 2 days, except if someone discovers you quickly and takes you to hospital. So that's why we don't encourage its use like before, since there are better medications now.
Okay, thank you. So we have a question for Fury. In cases where a patient has diabetes along with other comorbidities, and there's also polypharmacy, which would be inevitable, how can the patient be encouraged or counseled to take their medication, and how can pill burden be reduced?
Yes, when a person has a lot of comorbidities, and quite a number of patients do have them. Some patients have hypertension, diabetes, dyslipidemia, and arthritis, and each of these requires like 2 to 3 medications. So you find that many of such patients are on 10 different tablets. The way to help such patients is to use more of the fixed dose combinations, which means medications that contain 2 or 3 drugs combined together. For instance, in the antihypertensives, there are some antihypertensives that are actually 3 drugs together. And then there are some hypoglycemic agents that are also 2 medications combined together. That helps to reduce the number of tablets the person has to swallow. And then sometimes it helps to tell the person that, okay, you could take these ones in the morning, you could take these in the afternoon. Because sometimes having 10 tablets in your palm is quite formidable for quite a number of patients, and they become panicky. So you could help them to space them.
Great, thank you. Please, could you put your contacts in the chat? There are a few people asking if they can reach you outside this forum.
Okay, I'll write my email so that they can
Thank you. All right, Vivian wants to know about the implanon contraceptive. Does it predispose to diabetes? And why does it cause truncal obesity?
Well, most of the contraceptive agents are steroid-based, which means they contain either estrogen or progesterone. And most of these steroids, they do encourage fat deposition around the trunk. So if you're on prednisolone, dexamethasone, or any of the steroids, most likely you'll put on weight faster. And the best thing to do in such people is to increase your exercise, increase your diet, improve your diet, and then do these on a regular basis. That will limit how much fat you do deposit around your midriff.
Okay, thank you for that. Nikki is asking, with your experience, have you seen issues with diabetic patients using thiazide-like diuretics like indapamide? She says, I know they can induce diabetes, but some doctors don't consider it as a problem, whereas others do.
Yes, in the olden days, in the 80s and 90s, a lot of patients used to be on moduretic and brinadine. These are thiazide diuretics, and then some were on hydrochlorothiazide, bumetanide, and so on. These type of drugs will cause raised cholesterol, raised blood sugars, raised triglycerides. And that is why nowadays you don't see many physicians place patients on thiazide diuretics. And if they do that, they make it a small dosage, usually 12.5 milligrams. But the other diuretics, such as indapamide, they do not have as much effect on triglycerides, lipids, and blood sugars. But we do know that most diuretics, they do cause some degree of metabolic derangement.
Thank you very much, Prof. Any more questions before we move on to our final speaker? Okay, Donald. If a diabetic travels to the village because of inconsistency of power supply, can insulin be preserved in room temperature water? Is that opened or unopened? Or, well, either one, Prof. You can answer both.
Well, if you're traveling to the village, like many of my Eastern brothers around Christmas, just get maybe some ice block or get a flask and drop your insulin inside. Put ice inside the flask and take your insulin inside, or a cooler and put chips of ice inside. That should take you to the village. And when you're coming back, you do the same. If you don't have a food flask or a thermos flask, then just keep the insulin close to the floor in the room where you are residing in a bowl of water. That will keep the temperature between around 25 to 30, which should be able to take that insulin for a few weeks.
Thank you very much, Prof. We'll move on to the next speaker. Any more questions we'll take at the end.
Thank you.
Thank you very much. So our next speaker for today is Folashade Lawal. She's the MD and CEO of Victory Drugs, and she has over 30 years experience in community pharmacy. She is also an associate member of the Royal Pharmaceutical Society and a fellow of the Pharmaceutical Society of Nigeria. Over to you, Mrs. Lawal. Please share your screen. Okay. Yeah, we can see that.
Good afternoon, everyone. Can you hear me?
Yes, we can. Go ahead.
Hello.
Yes, we can.
Okay. Good afternoon, everyone. I'm highly delighted to be with us this afternoon, and I'm grateful to Gintavenes for this opportunity. Thank you all. It's been a wonderful day. So I'll be sharing with us briefly in about 10 minutes, role of the pharmacist in the management of diabetes. You will agree with me that I will just talk on a few because 10 minutes is a short time. So we'll be looking at the pharmacist, and then we'll talk about the different ways by which pharmacists care for diabetes patients. A lot has been said by my previous speakers, and they've done great justice to diabetes. So the big global health challenge. Now, let's look at peculiarities of the community pharmacies in management of diabetes. Easily accessible. You don't need any prior arrangement to get there. You can just walk into any pharmacy. We have highly skilled frontline healthcare professionals. We are a great resource for health promotion and disease prevention. The community pharmacists are trusted by the public. We are known in the community where we practice, and at the heart of the pharmacist is care. We're trained to care. So we look at roles of the pharmacist in the management of diabetes. As we all know, prevention is a lot more cost effective, better, promotes health, much more than cure. So we'll be looking at our roles in the 3 levels of diabetes prevention. And those 3 levels are primary, secondary, and tertiary. At the primary level, we are looking at those who are not yet diabetic, probably pre-diabetic, those with risk factors, and we want to help them out not to become diabetic, or if they must have diabetes, to prolong the time it will take for them to develop diabetes. So pharmacists come in strongly here. Pharmacists also help out with secondary prevention, whereby we're looking at patients who are without symptoms, but they are diabetic, and those who are diabetic but also at risk of complications. I will talk a little on that. Some patients, they don't present with any symptom at all, but they are diabetic and they are going about and nobody knows that they are diabetic. They themselves don't know that they are diabetic. Such patients need to be fished out, and the community pharmacists are available to help out there, because many times we just do random sugar tests, and some of them just from their sugar tests just find out that they are diabetic. Then tertiary prevention, that is to delay the consequences of diabetes complications like blindness and amputation. That's by helping the diabetic patient to manage his diabetes properly, control his blood sugar. And when we do that, even if complications arise, it makes it easier for us to prevent consequences of the complications. Like, we know blindness is irreversible, amputation is irreversible. So one of the things we do is what we call medication therapy management. By this, we identify medication-related problems. For example, we want to know if the medication that this diabetes patient is on is appropriate, because Professor Fasah just talked about individual management. It's not just mini more with drugs. No, there has to be a lot of considerations. So we want to know if the dose is appropriate, if it is below what it should be, above, whatever medication-related problems are. So when we find this out, then we are able to solve them. We also help the patients to assess their medications for nutrient depletion. For example, Metformin moderately depletes folic acid and vitamin B12. Sometimes that necessitates supplementation, and we can easily supplement for that. We also help patients get better understanding of their medications. By the time patients understand what these medications are, what the medications are doing, the importance of taking, then we will be promoting actually, because the patient is more likely now to want to take the medications as prescribed. Or if there are concerns, the patient will express these concerns, and then we're able to work around it. We also help to assess for lifestyle. We have had a lot of talk about lifestyle by my previous lecturers. Then we also assess for CVD risk. There's a way we can help the patient to calculate their CVD risk and then intervene appropriately. In the community pharmacy, part of the medication therapy management that we do is to assess for vaccination status. Especially, we know that diabetes patients are always pinching themselves to get out blood. So it's just appropriate for them to be protected from hepatitis, which they can easily get from that pinching. So we assess their hepatitis vaccination status and advise accordingly. We also make recommendations to their GP, consultants, or other healthcare professionals that are managing them, so that we are all focusing on the patient. You will agree with me, diabetes management is multidisciplinary. Of the various healthcare professionals have various roles to play to ensure that we optimize management. So we also make recommendations to the patient or the caregiver. For example, we might have to write out certain things that must be done. We help the patient to know what time. Professor Fasah talked about appropriate storage and then sorting out the drugs. So we make our recommendations to the patient. Now, one of the very interesting things that we do is to promote diabetes self-management, because it's all about you. Diabetes, if you are diabetic, you must be at the driver's seat of that diabetes car. It's like you are driving a car. You are the driver's seat, because you are the one who feels, you are the one who knows what is happening to you, and you are in the best position to express yourself and get help as the case may be. So you should want to know everything about your condition, and the best way to go about it. So we help you by providing information, linking with other healthcare professionals to promote self-management, which is very key. Other duties of the community pharmacists, we do public education on diabetes prevention, including weight control, increased physical activity, and control of blood pressure, lipids, other factors that might affect your diabetes. We have to identify pre-diabetes patients and intervene to prevent or delay progression to diabetes. Like we learned earlier, there are so many pre-diabetes patients in the community. For almost every one diabetes patient diagnosed, there are 5 other pre-diabetes patients. So we have to look out for them so that we help them to delay or prevent onset of diabetes. Screening for yet to be diagnosed diabetes patients, we do that from time to time in community pharmacies. I recall we had some experience some years ago. We're just doing general screening, and this patient that had always treated malaria all the time, malaria. He came for this screening, and surprisingly, it's randomly, he never checked that before. And that was the first time he was being picked up to have diabetes. We also have to identify potential complications and intervene. We have to pay attention to siblings and children of diabetes patients. We know that family history is a strong risk factor. So we also look out for them so that we are engaging them and helping them to pay particular attention to lifestyles that will not allow them to develop diabetes or delay progression, onset of diabetes. We collaborate with other healthcare professionals to optimize diabetes care. That is justice. We work together with GPs, dietitians, nutritionists, laboratory scientists, nurses. We work together to make sure that we are optimizing diabetes care. We provide diabetes ancillary products like calorie sweeteners, glucose tablets. Glucose tablets are necessary to counter hypoglycemia. For example, diabetes patients are advised to have them handy in case something happens along the line and they start having symptoms of hypoglycemia. They will need to quickly do something about it. We also stock things like diabetes socks and shoes. We engage in outreaches, community screenings. We also help us with checking diabetes fits, which is one of the targets of diabetes, to make sure that their fits are all right, and if they need attention, to intervene as promptly as possible. I'll briefly look at a few cases here, 2 of them. There's 65-year-old Mrs. Z, and she came to us wondering why her diabetes was poorly controlled despite eating only twice a day. It's not about eating twice a day. In fact, it's better that the meals are not lump sum at once. It's also, we have listened to the dietitian early earlier, and she helped us to know that the quality of what we eat must be balanced with quantity. There's just no compromise along there. So we're able to do what we call 360 degrees measure with Mrs. Z. That we're able to look at the various meals, time them with sugar level, and we're able to resolve areas where she needed to make adjustments. 50-year-old Mr. Eri was passing by and saw the banner asking people to come in for free diabetes check. His random blood sugar was 500 milligrams per DL. He was surprised because he came in as he just wanted to check. And then he said he had been diagnosed diabetic some years back. He had been on medication but stopped because he took some other remedies that he said cured his diabetes. Diabetes is something that we manage, and whatever is done to get it to the normal value has to be continued. Otherwise, there can be a reversal. There can be, I mean, the diabetes is still there anyway. So we had to cancel Mr. Ari and get him back to see his doctor. And by God's grace, everything was solved. So other services that you can get from your pharmacist in summary: diabetes prevention, prompt and adequate referral, filling of prescription and counseling, diabetes education. We do point of care tests, like we check for your A1C, we look at your lipids, then immunization, medication checkup, which is very important. A number of people take so please don't take medications that were not prescribed for you. We talk about them. I recall somebody who was on insulin and metformin and thought that he was not doing well on it, and a friend offered him Daonil and he was going to add Daonil to that combination. So we need to do medication checkup. We've seen so many things. Some patients add different kinds of herbals and they just complicate issues by what they take. So we need to look at them and help them to sort out medications. Apart from that, some people necessarily have to be on many medications. We heard Prof talk about patients on prednisolone and some other medications. If it's necessary, doctors they have to be taken. But we can help them to sort them out or we make the most of the interactions to optimize their drug management. So we offer adherence support. By the time we are able to sort the patient out as to when, how, the need for this medication, we are encouraging adherence. We do fit examination. We do diabetes. We have what we call diabetes support group. You will agree with me that when you are with peers with similar conditions and you rub minds, you exchange ideas, it goes a long way to help. So for us at Victory, we have what we call Victory Diabetes WhatsApp group. I'm sure many pharmacists have other groups too that they use to help diabetes patients. So I will conclude by saying that your pharmacist in collaboration with other healthcare providers can help you to prevent diabetes, can help you to prevent diabetes complications or reversible damage from diabetes complications like blindness and feet amputation. And I want to appreciate God Almighty for whose will is that we prosper and gain. Gintavenes again for all that you represent to us. Gintavenes Foundation led by Dr. Agun, and then our communication consultant who designed. Thank you for listening. God bless you.
Thank you very much. Thank you, Mrs. Lawal. Thank you so much. Yes, I can hear you. Please stop sharing your slides. We have a few questions for you. Can you hear me, Mrs. Lawal?
I think so, yes.
That's great. Okay, so the first question is to do with alternative medicines such as Agbo. So the question is what's fearing. On the issue of alternative medicines such as agbo concoctions, herbal remedies, what can be done to stop the use of these concoctions? Because majority of them are not even standardized or have NAFDAC numbers, as most of us are aware. How can those selling them be regulated? I don't know whether that's a question you can answer completely, but at least you can try and give some insights.
Like you have said, the regulation lies in the hands of the regulator. So I'm not in a position to regulate that. The best we can do really is to talk to patients and help them to see the dangers in combining, in taking medications or, well, so, you know, many times they tell them it's just herbal. It's not a medication. We let them know that these are medications and they have not gone through clinical trials. We don't know, we don't have information on them. Because we don't have information on them, we are not authority on them. So why do you want to take something that we don't know about, you don't know about? So the best we can do is to help them to understand the dangers inherent in taking them, while we leave the regulators to regulate.
Yes, indeed, we leave the regulators to regulate, absolutely. You mentioned about feet examination. One, why do diabetics need to have their feet examined and how often? And that correlates with the question from Landry, why do diabetic patients get amputated? So that's why I've asked it in that order.
Well, as we all know, blood flow to the extremities in diabetes is very sluggish because of the sugar in the blood. So generally, those areas are starved of oxygen supply, and they easily come down with problems that have to do with well, I'm trying not to use very big words, well, neuropathy and all that. So sometimes they don't have feelings in their feet. And if their feet have any form of injury, they may not even know. You see, diabetes patients sometimes they put their feet on hot things and they get burns without feeling it. So they don't know when the injury is taking place. And that's why we need to look out, because those injuries too, just as they can easily occur, unfortunately, they are very difficult to treat for the same reason that blood flow to that area is impaired. So we need to pay attention to their feet. And if it gets so bad, they may have to amputate the feet. So feet amputation is more common in those living with diabetes than those who are not living with diabetes for this same reason. So ideally, they should have their feet thoroughly checked annually if all is well and they don't have problems, and then they need to be taught how to care for their feet, which is very important. When they are taught how to care for their feet and their feet are examined thoroughly annually, they can have intermittent checks, like in the pharmacy. They can walk in and the pharmacist just helps them to look at their feet. And once we notice anything wrong, we refer. But for those who already have issues with their feet, they need to see their podiatrist, and they need to do more regular checks of their feet.
Okay, thank you for that. We're talking about storage temperatures and storing insulin earlier. Now, Miriam is asking, in a situation where you enter a pharmaceutical store or pharmacy and it's greatly heated so that the heat is so unbearable, is it advisable or considered safe to buy any medication from such a pharmacy, taking into account the heat within the pharmacy?
That's a big question. Well, it depends on the storage requirement for the drug in terms of the temperature and the temperature inside the pharmacy. You know, we are in a very hot environment. And generally, pharmacists try to regulate or to improve or encourage, provide ambience in their pharmacies. But sometimes it's just not easy, because here you hardly get lights. That's just the truth. So sometimes there may be a little distortion in temperature. That does not necessarily, it's not immediately that the drugs have issues. But if there are drugs that must be stored in the fridge or at certain temperatures, then please check for those temperatures before you buy. It's your right to want to know, and you should know, because it's all about you. So be sure that those drugs are properly stored. I know that in many cases, this happens with non-pharmacy places. Some people go anywhere like that to get their insulin. And there are some stores, they buy so many of these cold storage drugs to keep them in the store. They just put a few in the fridge and they give you from the fridge, but they move the rest from the shelf to the fridge when you are not there. So that's why it's good to go to pharmacists and engage your pharmacist.
Thank you, Mrs. Lawal. Olabode is asking, at what age or time does one need to go for a checkup for diabetes?
Well, generally, checkups start at age 40. That's when people are most predisposed. But any age can check depending on the risk factors that are prevalent, depending on the condition of the person. So it depends on how the patient presents. For example, somebody who just, maybe a young lady, and she's always coming down with skin breakout boils, she's always having candida and all that. It's time to check her diabetes status, especially if there's a family history. So I don't think that there's any rigid definition in terms of the age, but we can ask Professor Fasah to tell us more about that. But I know that generally, many of these conditions start setting in when one is 40, because age is also a risk factor. So the older we get, the more likely that the body starts degenerating and having one issue or the other.
All right. Yes, we will probably put that to Prof when we have the panel discussion afterwards. Another question is, what is your take on bitter leaf water in hypoglycemia?
Bitter leaf water and hypoglycemia.
Hyperglycemia.
Well, like Prof said, the best thing is if you're on medication, stick to your medication. But bitter leaf is a food that you eat. If you eat it as normal food, that's fine. But to drink the water, we have to be careful there, because sometimes, yes, some of these herbs, they have blood sugar lowering effect, there's no doubt. But if you use them and then you combine with other drugs that will further lower your blood sugar, you might end up with hypoglycemia. Your drug has been titrated based on your lifestyle. So if you are going to be on bitter leaf water, let your doctor know, so that if he's going to make any adjustment to your medication, or you monitor your sugar properly, because bitter leaf is a food that we eat.
Okay, thank you for that. Vivian, I hope that answers your question. Then we have question from Osarenko. How can the community pharmacies help us calculate CVD risk?
Okay, we have scientific calculators for that. So the community pharmacist knows what to do to calculate your CVD risk. The community pharmacist will need information on your blood pressure, we need information on your lipid profile and all that. So there's a calculator that will feed in all the necessary data, and then it will give us your CVD risk.
Great, thank you. I think those are all the questions specifically directed for you, Mrs. Lawal. Thank you very much for that. So now we're just going to throw out questions that we couldn't handle during the individual speakers. So the first one is, just looking for that. There's been quite a lot of chat. I had it just now. Just give me 1 second. Okay. So the question, I'll put to Prof and Mrs. Lawal. Can a diabetic patient use Glanil? Now, I think that is a brand name in Nigeria, which we do not have in the UK. So what is the active drug in that brand?
The active drug inside Glanil is glibenclamide or glyburide.
Yes, so Boston is asking, can diabetic patients use glibenclamide?
Yes, a person with diabetes can use it, but usually it has to be a younger person with diabetes. You don't want to put an elderly person or a middle-aged person on glibenclamide because of the reason I mentioned earlier. You might have a severe hypoglycemic episode if you are not careful.
Okay, thank you. We have a question from Facebook for you, Prof. Is the Prof aware of any studies comparing the effectiveness of metformin in Black men versus Caucasian men?
No, I'm not aware of any studies that have been published, but maybe Carol might know. I don't know any studies that compared metformin in blacks and whites, no.
Okay, Dr. Gale?
So I'm also going to say the same. So metformin is a very old drug, but interestingly, if there is any data, it would have been from America, where they did Glucophage is the brand they use in America, and that's actually only been licensed for use in America for maybe, I think, 10, 15 years. And the American data wouldn't compare if you're Caucasian versus if you're Black, but it would tell you they included individuals who were from Black different groups within the study, which they are usually required to do. And they would look to see if there was a difference in the response. So I think that's the only way I can indirectly say it, because metformin has been used in many countries for 40 and 50 years. But it would be within the American data. What I would say that as far as I'm aware is that there isn't a difference, and that metformin is the first line recommendations pretty much around the world in most national diabetes associations recommendations for treatment. I think it's one of your first line treatments as well, Professor?
Yes, it is. It is.
Okay, thank you, Dr. Gale. Prof, do you want to speak to the question that was put to Mrs. Lawal in terms of at what age, or even Dr. Gale as well, what age or time does one go for a checkup for diabetes?
Well, I think most people will say middle age, you should start checking for diabetes, although we know that worldwide, the age of onset of diabetes mellitus has continued to drop. And I would say for a person who doesn't have diabetes in the family, I would say you should start going for HbA1cs or blood sugar checks when you're above 40. For a person that has someone in the family that has diabetes, I would say start checking a decade earlier. The reason why you don't want to check in children or people who are very young is that you have what looks like check fatigue. You start checking your blood sugars from 20, 21, 22, 23. The tendency is that you tire out and you no longer want to check again. So the yield in those ages is small. The highest yield for picking up people that were previously undiagnosed is highest when you use the people in the middle age, so 40 and above. Then also, if you check people that already have hypertension, you find that quite a number of them, about a third of people with hypertension will also have diabetes. So that is another group that you want to check regularly. And then people living with HIV/AIDS, you also want to check them much earlier, even if they're in their 20s, you want to have their blood sugars checked. So the age at which you check depends on the community, depends on the comorbidities, and several other things present.
Okay, thank you. Yeah, go on.
So I would say I completely echo all of the professor's sentiments. You know, we can't cover every different individual risk factor, but the interesting thing that I found using those Diabetes UK and ADA websites is it does allow you to put in some of your individual measurements. It doesn't include all the risk factors as the professor's outlined, but it helps you to be able to maybe assess yourself to think, should I now be going to have myself checked? In the side of recommendations that the professor said is also for if your family history, you may be addressed earlier, but if you use the risk factor things, which assess risk factors assessment tool, you can put in your individual measurements, which will then tailor that a little bit more and help you to decide maybe it is time for me to go forward and get myself checked.
Right, okay. There's a lead on to that. Again, back to cardiovascular risk. When should someone who's living with diabetes come in to check their cardiovascular risk? How often in a year, for example? So once a year, how often? Anyone can take that.
Well, I would say yearly, but Dr. Gail can also chip in, because I believe once you have any of the cardiovascular risks, whether it's erectile dysfunction or intermittent claudication or chest pain, you should check every year.
I would echo that. That's meant to be part of why you should be having your diabetes reviewed very regularly. We know that many people, as people on the panel described, may have diabetes but not necessarily have symptoms. And part of the screening is to reflect your cardiovascular risk score, look at things like your cholesterol measurement, your blood pressure, if there's any protein in your urine, so that you pick these changes up early, and therefore the prevention gives you the maximum benefit, because many of the therapies are designed to delay progression and give you a better quality of life over the long term. Because when you live with diabetes, you will live with it for a long time, and what you want is for those treatments to give you a good quality of life and delay or prevent you getting the complications, which are really distressing for many people.
Okay. Mrs. Lawal, any comment on that?
I didn't get the question.
It was how often people living with diabetes come into cardiovascular risk.
Sorry.
Go on, we can hear you.
Once a year is good enough. Yeah, depending on what the findings are. If there are issues, then we have to check regularly. Or if it's just for routine check, once a year is good enough.
Okay, thank you. We're back to bitter leaf liquid, bitter leaf water. Miriam is asking, we were told that drinking of bitter leaf liquid is bad and harmful, but now there is a capsule, apparently, a bitter leaf capsule to help reduce diabetes. Any comment, Prof?
I usually, what I do tell my patients is that orthodox medicine or Western medicine, most of them did have their origins from either Chinese roots or African roots and so on. But I do let them know that I am a professor of medicine, not of pharmacognosy, and I'm not a traditional medicine practitioner. So what I do tell patients who want to experiment, I say, well, if you're taking all the medications I put you on, and someone is giving you bitter leaf water or ugu water or any of the other leaves, either as powder or as water, please watch your blood sugars, just in case they have a potentiating effect on the blood sugars. And I advise them not to discontinue the Western or Orthodox medicines, because some of them are told to drop their Metformin and all the other drugs and go for the herbal medications. And for those who insist on wanting to embark on that journey, I tell them, please keep monitoring your blood sugars, and I'll be waiting for you when you do come back with trouble.
Sorry. Could I add, when I have this conversation, like the professor, I would be the first one to say, there is no doubt many herbal preparations do have an effect on your blood sugars. This goes without saying. The difference is what I would say to somebody that comes to me to discuss this is I'm open. Like the professor said, I'm not an expert in that area. But what I would say is when you come to see me and I recommend a medication for you, what's the first thing you ask me? And they will always say, before, any chance of me prescribing this, they'll say, what are the side effects? All right. And they'll go away and diligently read the sheets even after they said they would agree to take it. And that's right, because that's been an intelligent person, because you've got to do an assessment about, does that work for you? What interests me is, that's absolutely right. what interests me is that, and certainly the English parallel, is as soon as somebody hears the word herbal, they'll go to Holland. And in England, we have a chain of shops called Holland and Barrett that does high quality herbal preparations. Do they ever ask the person in the store, what is the side effect of this herbal preparation? And herbal preparations, if they have an effect, also will have side effects. And I find it interesting that they'll talk to a shop assistant who has no expertise and buy it, take it, but not apply the same level of due diligence to their self-care to say, what are the potential side effects? So that's the, you know, this is just a discussion point. But I will be the first to say, and so the issue with a lot of herbal preparations is the availability at different times of year, the potency, the regulation of it, it's not standardized, which with, if you like, my religion of orthodox medicine, if we use that phrase, is that is my expectation, is that I should be able to tell people what they expect, how it works, and what side effects they may need to look out for.
Absolutely, yes. Thank you, Dr. Gale and Prof. Another question, do you find that the degree of comorbidities, like heart disease or renal disease, kidney disease, does that determine the amount or type of medication used for the management of type 2 diabetes?
Well, to some extent it does, because a person who has kidney disease is likely to be on one extra medication to prevent further deterioration. The one who is who has angina or any other heart problem will also be on extra medications for that. So the more the comorbidities, the more likely you're going to be on a lot of medications. Although there are some medications that have effects on several organs. And for instance, there are some of the antihypertensives like the ACE inhibitors and the ARBs, which will help both the heart, the kidneys, and the vessels. But usually persons with more comorbidities usually require more medications most times.
Dr. Gale?
I don't have anything else to add.
Okay, very great. Okay, so we have some comments in the chat. Great session. Thank you to all the wonderful speakers and a wonderful session and great areas experts. Thanks for this informative session. It's a great session, wonderful speakers. Now, what I'm going to ask each speaker now is, what is the one take-home message you want people to live with? So that's what
sorry, just before we do that summing up,
yes,
there was a theme from, I think it was Lyon, that I feel it's really important that we should talk about, which is around language and describing.
Oh yes, sorry, I was going to bring that up at the end. Go ahead.
Several times, and I think it was really appropriate because one should always be challenged and be able to think about how you practice. He was saying that the use of the language that we use for describing people who have diabetes, his point was language matters. We consider that in many different spheres of life, and that we shouldn't be using words like diabetic. It's a person living with diabetes or a person that has diabetes, themes along those lines. And actually, I do agree with him. I suppose the parallel that I draw is were trained in a generation where we did use words like diabetics, whereas people who have diabetes, and it's part of what they live with everyday life. And it does take us time to change our use of language and change our behaviors. And it's good to be challenged so that you continuously look at how you do use language. Just like we would be challenging people, and if you like, this will lead into my final messages, you can always do something from a lifestyle perspective that will benefit you. And you have to keep on addressing it because we're human. We adhere to things and then we fall off the wagon, if you like, and then we get back on it. And that's just recognizing your human frailty. But he's absolutely right, language matters.
Thank you very much. Prof, do you want to say anything about the issue of language?
Yes, it's usually how doctors refer to patients It's something of habit, and it's difficult sometimes to teach an old dog to learn new tricks, but you must make a conscious effort to refer to people who have diabetes as persons living with diabetes or a person with diabetes. Just like people that have leprosy will not want to be referred to as lepers, they will probably prefer to be referred to as people that have Hansen's disease or people that have leprosy. People with hypertension will not like to be called hypertensives because it has some derogatory tone. But usually you find that doctors often forget and then they go on using these terms without knowing that it affects the sensibilities of their patients. It's a different thing if they use that in their own conferences where there are no patients, but I think generally it's better to use the same language everywhere so you are used to it because that might be the one thing that turns off your patient. And for final words, I would say if you have diabetes, don't give up hope. People often ask me, how long am I going to take these medications for? And I tell them, well, nobody asks how long you are going to eat for or drink water for. Take medications as though your life depends on them, because very often it does. And there's really nothing wrong with having to take 1 or 2 pills every day. Or take away from you.
Thank you. Thank you, Prof. Mrs. Lawal, final take-home message? Final take-home message, Mrs. Lawal?
Can you hear me?
Yes.
Okay. Well, it's important for us to understand that diabetes is a condition that can be managed and is being managed. So it's good to carry your healthcare professionals along. It's better not to assume or take unnecessary risks. So like I said in my presentation, you should be at the driver's seat. But your work at the driver's seat is to protect yourself. And the way to protect yourself is to make sure that you go with your healthcare professionals. If you have concerns, please express them so that they can be trashed. Don't just decide that that doctor doesn't know what he's doing and then you change the prescription behind him. It's good to carry everybody along and do your regular medication checkup, especially when you find that you are seeing so many different prescribers for whatever conditions you have. So it's good for somebody reconciling your medications, and that person is your pharmacist. So book for medication checkup, or what we call medication therapy management, from time to time from your pharmacist. Thank you.
Thank you very much. Thank you. Any more questions? Any final questions before we round up? Last chance. Just to let everyone know, if you've missed any part of the session, we'll be uploading it to the YouTube channel later today or tomorrow, so you can go back and watch any bits that you wanted to catch up on. Okay. Yes, Dr. Agum.
Don't forget John's vote of thanks.
Yes, I was just going to do that now. Yes, I was just going to do that now.
No problem.
All righty. So, John, I'm going to hand over to you now.
Hello, good evening, everyone. Can you hear me? Can everyone hear me?
Yes.
Okay, fine. Good evening, everyone. Thank you for being with us now today and spending the evening with us, sharing and learning all the things that we've had to learn. It was quite a rich program. My name is John Akere Sangbedo, and I'm the project manager for Gintavenes Health Foundation. And then everything that we do here, actually, all the things that we do, everything that we try to accomplish, all of our interventions are made possible by charitable donations made by individuals such as yourselves and organizations, well-meaning organizations who contribute in one way or the other. So, of course, I've been charged to give the vote of thanks this evening for this talk. And I want to start by saying thank you to everyone that's been able to attend and take out time from the busy schedule. So I know this is a very difficult time, but we're here, and I'm sure we all learned a lot because it was very rich. I learned a lot about diabetes and managing it, risk factors associated with it. On behalf of the Board of Trustees of Gintavenes Health Foundation, thank you on behalf of all of our collaborators. Thank the collaborators as well, our facilitators, and everyone that's here in this meeting now and that's been able to share with us today. Going back to what I said about charitable donations, Gintavenes Health Foundation lives totally on charitable donations, and we'll be very happy to keep putting up interventions of this sort, meetings of this sort, and very soon physical trainings and all that for healthcare practitioners as we've been doing in the past. But all of these things cost money, and monies that we always get from well-meaning people and charitable donations, as I've said. So what I'll do is I'll try and share my screen now where we have our account details. If everyone, can you all still hear me?
Yes,
Yes, okay. Let me try and share.
Don't forget to thank our speakers.
Yes, I'm going to. I think I've done. I'll go over that again though. I'm sorry. I seem to be a bit flustered. I'm not doing a good job, but that's
they put in a lot of work.
They put in a lot of work. Even the technical difficulties that we've been experiencing from the beginning, people will know this, but we spent 2 hours beforehand trying to iron out the kinks, and it was working, fine before everything started. I think let me try and share my screen. Share screen. Share. Okay, so up on the screen, we'll have the Gintavenes Health Foundation official bank accounts for people who may be interested that are on here now in making a donation to us, to the foundation, so that we can keep putting up interventions of this sort. And then something else I don't want to forget. Then we're also on Facebook. You can follow our activities on Facebook as well as our YouTube channel. As Pharmacist Flora said earlier on, we'll be uploading this session for those of us that missed 1 or 2 things while people were speaking and getting cut in and cut out and all that. You can always go to check out our Gintavenes Health Foundation website, not the website, the YouTube channel, and then get the recording of this session. So I want to say thank you to all of our speakers. Thank you very much, all of our facilitators, all of our technical people that have been in the background and everything, getting this thing up and running. And we hope that everyone stays safe and we meet again like this in happiness very soon. Thank you.